Okay, we are at 12 o'clock, so we are going to go ahead and get started. So, hi and welcome everyone. Thank you for joining us today for the UNC Injury Prevention Research Center webinar series. My name is Ciara Scott, and I am a project manager at the Injury Prevention Research Center, and I will also be moderating today's webinar. We will begin today's webinar with a quick welcome from Dr. Steve Marshall, who is our center director. And then he is going to introduce you all to our speaker for today, Dr. Tolu Oyesanya. And then we will have an informative presentation from her, followed by some dedicated time for questions and answers from you all. And then we'll wrap up today's presentation just by briefly forecasting our next webinar and upcoming events. And so before we get started, I just want to give a quick housekeeping update. You all may or may not have noticed that we have disabled your mic and camera functions for the time being. And this is just so that we can protect the recording from any accidental disruptions. But once we get to the Q&A portion of the presentation, we will give you the ability to unmute to ask questions and engage with our speaker. Also, throughout the presentation, if questions come up, please feel free to drop those directly in the chat. I'll be keeping a list of those, and when we get to the question and answer section, I will bring those questions to our speaker. And so now I'm going to pass the floor over to Dr. Steve Marshall, again, our director here at the UNC Injury Prevention Research Center.
Hey, thank you, Ciara. I want to welcome everyone to this seminar, and also want to mention our Associate Director, Dr. Beth Morocco, is also on the line. We are excited to have Dr. Onyesaya here today from Duke University, and want to mention that these webinars, we view them as a really important way to create collaboration between the practice community and the researchers. And also want to recognize, I see several people have identified themselves as TBI patients or TBI caregivers. And we really want to acknowledge, the seriousness of this injury and the toll it takes on families who suffer from it. So thank you for coming out today. We appreciate that. I am so excited to have Tolu here today. Thank you for coming along. She is an associate professor at Duke University. She's PhD trained as a nurse and health services researcher. Her research focuses on patient and family-centered care and support, particularly around TBI. And she is an expert in qualitative methodologies, which are so important in this area in order for us to, understand the true impact of this injury and how we can optimize the services we deliver to families. And she is a triple threat BS, Master's, and PhD in nursing from Wisconsin-Madison, a great university. And she did her postdoc at the Shepherd Center in Atlanta. So obviously that is a really impressive TBI care facility that, I've had the opportunity to visit with them and really love what they do down there. She is actively involved in a large number of professional organizations. And when she was in Atlanta, she was part of the group associated with the Injury Control Research Center at Emory University. And here at UNC, we're a CDC-supported Injury Control Research Center as well. We have a lot of collaboration with our colleagues at Emory, of course. And so we were super excited to hear that she was coming to the Triangle, albeit to the other campus 9 miles down the road from us. And then a couple of things came off the rails, like a global pandemic and everything else. So finally, we are here to the point where we are going to host a webinar from Dr. Onyesaya. So without further ado, please take it away. We're excited to hear your presentation, Care and Support of Adult Patients with Traumatic Brain Injuries and Their Families Across the Treatment Continuum.
Thank you so much for that wonderful introduction, Dr. Marshall. I would like to check, can everyone hear me okay? Great, wonderful. Well, hello, everyone. It is an absolute pleasure and honor to be here today. As Dr. Marshall mentioned, my name is Tolu Oyesanya, and I am an associate professor at Duke University in the School of Nursing. And I will be presenting today, sharing a little bit with you all about the work that I have done in care and support of patients with traumatic brain injury and their family caregivers across the treatment continuum. Dr. Marshall has already mentioned a lot of information about me, but just to wrap it all into a nice bow, as he mentioned, I am from Wisconsin. I'm a Badger 3 times over. I know there is a little bit of a rivalry going between Duke and UNC, but Wisconsin is actually where my heart lies. After I finished my degrees at Wisconsin, I headed to Shepherd Center in Atlanta to do a postdoc, and we had some support from Emory School of Nursing. And since 2018, I've been on faculty at Duke University in the School of Nursing. My initial clinical background is as a rehabilitation nurse, but since then I have completed my PhD and now focus more on academic nursing, studying clinical problems to try to generate knowledge to improve nursing science, as well as care and support of patients with traumatic brain injury. And I also do some qualitative work. So today I will be discussing the 4 areas that my program of research focuses on. These areas are informed by my initial clinical work and have since become more refined and focused based on the research findings that our team has developed. Those 4 areas are healthcare provider support and decision-making, stakeholder experience, intervention development and testing, and disparities in health and healthcare. And this work also encompasses 3 distinct yet linked groups: patients, family caregivers, and healthcare providers, again, all relating to traumatic brain injury. So first, I'll cover a little bit of background to help to put things into context. Traumatic brain injury is defined as a bump, blow, or jolt to the head, or a penetrating injury that disrupts the normal functioning of the brain. TBI can be characterized as mild, moderate, or severe, with more severe injuries causing worse impairments in cognition and communication, physical functioning, and psychosocial or emotional functioning. Now, taken together, these impairments cause a loss of independence on the part of the patient, which can have a significant influence on the family. Research shows that there are significant racial and ethnic disparities in TBI-related outcomes. For instance, Latinx and Black patients compared to whites have higher rates of the overall incidence of traumatic brain injury and hospitalization, worse injuries at the time of discharge, worse outcomes, higher rates of readmission, lower rates of return to work, and a higher need for care, but unfortunately less access to resources. And these issues often result in more reliance on the family. Transitional care is defined as actions in the clinical encounter that are designed to ensure the continuity and coordination of healthcare for patients who are transferring between different locations or levels of care. And my work focuses specifically on the transition from acute hospital care to home. Now, although there is limited TBI transitional care literature, we know that our patients and families are struggling after injury. This is evidenced by high rates of rehospitalization, difficulty navigating the healthcare system, as well as research that shows they have a desire for more support from providers as they transition home from the hospital. However, there are limited TBI transitional care programs that are available. This might be due to the fact that there are no US TBI transitional care standards to use to inform development of interventions. In addition, the few existing interventions that are available do have some limitations, including that they are not effective for patients and families who are racial and ethnic minorities. They don't incorporate family members into the intervention, even though family plays a massive role in supporting our patients after they go home. And these interventions also do not focus on quality of life. So our team's ultimate goal has been to develop and test a TBI transitional care intervention to improve patient quality of life for diverse younger adults with TBI and their families. And all of my work to date has collectively moved me and my team towards achievement of this goal. And I'm going to give you a little bit of a summary of some of that work today. And so we'll start with my first research area, which is healthcare provider support and decision-making. And so my initial work on healthcare provider support and decision-making included development and testing of an instrument that I titled the Perceptions of Brain Injury Survey. This instrument assessed nurses' perceived knowledge and perceived confidence related to caring for patients with traumatic brain injury, as well as what type of training they had to care for these patients and how ready they felt to care for these patients. Our findings showed that although nurses care for patients with TBI very often, they had high perceived confidence, but low perceived knowledge. Since then, the instrument has been requested to be translated to three languages, including Thai, Malaysian, and Saudi Arabian languages. My other studies in this area showed that nurses had limited knowledge about caring for patients with TBI during the chronic phase of recovery, and also about community-based resources. We also found that there was a lack of consensus in the strategies that nurses use to care for patients with TBI who had cognitive impairments. There were almost 200 different strategies identified, so we don't have any standardized techniques that we're using. And then there was also variability in the standard and clinical judgment criteria that interdisciplinary providers are using to select the discharge destination for patients who are leaving acute hospital care. Turning back to the model, the next area in my research program is the TBI stakeholder experience, which captures perspectives of patients, caregivers, and providers. And not surprisingly, all of the work in this area is qualitative. So my studies in this area found that family caregivers work to protect the patient's safety during the hospital stay, mostly by working to manage visitors. They were actively filtering visitors who came in and out of the hospital to allow certain people into the patient's room and prevent others from coming in. Our subsequent studies found that patients and caregivers had concerns about the patient's wellness after discharge home, and that included medication management, health and wellness, and patient safety, but they were also open to using technology to address these issues. Another one of our studies found that patients, families, and providers had multiple recommendations that we could use to improve the transition from acute hospital care to home. And that included providing patients and families with more education, having more provider guidance from beginning to end, and addressing some systems level challenges. And that included coordinating follow-up appointments, implementing a patient navigator to support the patient and family as they work to navigate the health system, and development of a post-discharge provider follow-up structure so that we could have a way to easily get patients interdisciplinary care and support after they went home. The next area on my program of research is intervention development and testing. My team and I developed a TBI transitional care intervention for patients that are discharged home after traumatic brain injury, going directly home from acute hospital care without inpatient rehabilitation. And this intervention also incorporated their family members, something that was previously not done in the TBI literature. We named this intervention BETTER. BETTER stands for Brain Injury, Education, Training, and Therapy to Enhance Recovery. The intervention was informed by my prior research and some additional sources, which I'd be happy to go through those sources at the end if anyone's interested. The BETTER TBI transitional care intervention is implemented by clinical interventionists, and we call those individuals transitional care managers. A transitional care manager is a healthcare provider who has experience caring for neuro or trauma patients and is responsible for supporting and training the patient and family during and after the transition home from the hospital stay. In our feasibility study, most recently, our transitional care managers were actually occupational therapists. And so the 6 components of the transitional care intervention are listed here. The first is assessment of patient and family needs and referral to community-based resources. The second is patient goal setting and review of goals. The third is healthcare coordination, which also includes both updating and establishing contact with a primary care physician. The fourth is availability of the transitional care manager to answer patient and family questions and help them to navigate the healthcare system. The fifth is a piece on training related to self and family management and brain injury coping skills. And then at the end of the intervention, we do a warm handoff by referring our patients and families to the State Affiliated Brain Injury Association. So I'd like to share a little bit of the methods for the feasibility testing of the Better TBI transitional care intervention. The feasibility study occurred in 2021. It was a prospective quasi-experimental study. We just had the single arm, single group, meaning it was just the intervention to see if it was feasible. We did not have a comparison group, but it was tested at Duke University Hospital. For our sample, we recruited a total of 15 patient and family dyads. The patient and family were recruited together as they participate together in the intervention. For our patients, we did have the full TBI spectrum, including mild, moderate, and severe. And they were aged 18 to 64 years old who were planned for discharge directly home from acute hospital care without inpatient rehabilitation, and then their relevant family members. In terms of what we focused on, we mostly were interested in feasibility, including recruitment, enrollment, and data collection feasibility, but we also looked at intervention acceptability and the clinical outcome measures of the intervention. Our primary outcome of focus was the patient's quality of life as measured by the SF-36 by 16 weeks post-discharge. So here are some findings and lessons learned. We learned a lot of information. In particular, this study was extremely helpful to prepare our team, for a large randomized controlled trial. We found that our study was feasible, including recruitment, enrollment, and data collection, and was acceptable from the patient and family perspective. We also found that scores on the patient's quality of life, SF-36 outcomes, significantly improved over time. But we also learned multiple lessons. Two of those lessons were related to the speed of patient discharge and also the challenges we had in recruiting Spanish-speaking patients and families. In terms of patient discharge speed, almost 60% of the eligible patients that could have been enrolled into our study were discharged before we were able to approach them. And so we had to change our approach with screening and work more collaboratively with inpatient providers to get information in advance of potential discharge plans so that we could approach more patients. In addition, we had initially intended to recruit Spanish-speaking patients and families at the time of the study, but we realized it was going to take our team a lot more effort to build capacity to enroll Spanish-speaking patients and families. That would include translating our study materials and hiring and training bilingual staff members. And so that's actually a really great segue to my final research area, disparities in health and healthcare. So here's a bit more background to contextualize this work. There are multiple barriers to participation in transitional care research for Spanish-speaking patients and families. This is often because their needs and preferences are not captured in existing interventions, mainly because none of the existing interventions have either cultural or linguistic adaptation. So they don't have materials in Spanish, they don't have the capacity to support Spanish-speaking patients and families. Furthermore, there is low access to Spanish interpreters on the research side. On the hospital and clinical side, there are many strategies that health systems use to get access to interpreters. We do not have that same amount of resource available on the research side, at least not at Duke University. And so this limits our Spanish-speaking patients and families from being able to benefit from these programs and ultimately increases burden on families again. And so our goal was to build capacity to enroll Spanish speakers into our intervention through cultural and linguistic adaptation. And so here's the last slide that depicts our activities for cultural and linguistic adaptation. We did multiple phases. The first phase was cultural adaptation, where we did focus groups with patients, families, and providers. We then went on to do linguistic adaptation, where we did translation of all of our study materials, consents, workbooks, materials, scripts. And then we received feedback from Spanish speakers on our translations to figure out how to improve them. In the last phase, we first set out to secure the Spanish versions of our data collection instruments, and those that were not available in Spanish, we translated them. We then sent those translations out to native Spanish speakers, including 47 native speakers, to get their feedback on how to improve our translations. We learned a lot throughout that entire process. In terms of how to adapt our intervention, we learned about the importance of making sure we hire and train bilingual interventionists and research coordinators, because there is many limitations with using an interpreter for the entire 4-month intervention. If we were to have to go back and forth between an intermediary, it could be really difficult, and there also could be a lot of context and important information that could be lost. In addition, we learned about the importance of spending more time building rapport with our Spanish-speaking participants, as trust is something that is really important. We also learned about needing to plan for difficulties finding resources and services, especially for our patients that are either uninsured or even undocumented. And we also have a plan to develop Spanish language videos for our intervention as a way to consistently communicate information. We also learned some linguistic adaptation lessons, including using accessible language that is at a low grade level and is universally recognized by all Spanish speakers as simplistic as possible. We had a lot of new lessons learned about trying to find affordable ways to translate, knowing that if we were to outsource to third-party vendors, that translations can be very expensive. We found ways to do it with using bilingual undergrads to support us, but that did slow us down, but we were able to actually talk a lot more about the context that was important for our translations. We had some IRB variations. We avoided use of computers because computers don't take that context of translations into account. And then we also had to balance trying to follow IRB requirements, as well as making our participant-facing materials easy to read. In our last slide, the next steps are incorporating all of that feedback into our translations and our protocol, and then publishing on that work. And then also we have an R01 that is under review with NINR. It got a really great score, and so we are crossing our fingers and toes, hoping that it will be funded so that we can test this intervention with English and Spanish speakers, and if deemed effective, translate it to other populations. I'll wrap up by sharing a long list of acknowledgements. Special thank you to all of the investigators on my team. Without you all, we could not have done this work. Study staff, providers who have assisted with recruitment, funders, and a special shout out to my UNC collaborator, Dr. Lindsay Byam, who has been incredibly supportive and shared her expertise all along the way. I will end there. Thank you all so much for listening to my presentation, and my contact information is listed, and I'll open up for questions.
Thanks so much, Dr. Oyesanya. That was a great presentation and very informative. As I put into the chat, you all can feel free to drop questions in there if you have them, or you can use the raise hand function on Zoom, and I can call on you to unmute and ask them directly. So I'll just give a couple of seconds to see if any questions drop in the chat. So this is not a question, but just a comment. Participant Heather Katul has said, as a nurse of over 15 years, thank you for your compassion and care, because it is very needed. As a care manager from all settings, including inpatient, a lot of my job was stopping the DC before they were sent home.
Thank you so much for your kind words, Heather. I really appreciate it. And shout out to a fellow nurse. It's great to see another nurse here.
All right, it looks like we have one question from Beth. So Beth, you can go ahead and unmute.
Thank you. Thank you for such an interesting presentation. And I'm interested because TBI can sometimes result from intimate partner violence. And so, and actually it's kind of an under-recognized, source of TBI. And so I'm just wondering, like, if you have any adaptations or anything you take into consideration in terms of your intervention or your recommendations when dealing with a situation where that patient has suffered a traumatic brain injury as a result of an abusive relationship, particularly if the patient is still in that relationship.
That's a wonderful question. You are absolutely right that TBI could definitely result from intimate partner violence and is unfortunately undiagnosed as there's just so many cases out there that I think we could really bring more light to this issue. Within the intervention, at the very least with our feasibility study, we have not yet come across any individuals who sustained a traumatic brain injury as a result of IPV, intimate partner violence. However, when we think about ways that we might want to consider this for future study, it's definitely something that we need to consider. What we do in the intervention is we like to allow the patient and family caregiver to make decisions for themselves as much as possible. So one example is that we allow the patient to name their caregiver that they want to participate in the intervention with them. They can name whoever they would like, as long as that person is going to provide them with a lot of support after discharge. And so if they did not want to name their partner or the individual who might have been violent towards them, they're able to do so. We also regularly assess their safety throughout the intervention and have an escalation protocol in place in case the patient does not feel safe. But I do definitely think there are additional things that our team needs to think about when it comes to intimate partner violence. And I'd be happy to discuss further offline if that would be something that's of interest to you. Thank you so much for bringing up that wonderful question.
All right, we have another question in the chat. Scott Pokorny has asked, has your program worked with individuals with TBI who do not have family or other natural support? And if so, how do you address the additional challenges associated with this type of discharge?
That's a wonderful question. Yes, in our prior work, we have worked with a number of patients that don't have support. As we know, family support for patients can vary significantly, both in the availability and type of that support. And so it can be really challenging. We went back and forth multiple times about how we should go about recruiting patients into the study. Do they need to have a caregiver in order to participate? We ultimately decided on having a caregiver because of the amount of support that we felt was needed. But in subsequent work, I think we'll need to test this intervention to see, those individuals who do not have a family caregiver, could they still benefit from this? And I have a number of colleagues that are doing TBI transitional care work across the country that are grappling with this as well. And some of their studies, they can recruit patients individually, or with a caregiver, depending on what works best for the patient. It's definitely something that we need to think about. But I will say in all of the prior studies we've done to date, we did not have the requirement that a family caregiver needed to be available to participate, but more recently decided on it.
All right, and it looks like we have another question, or one last question, from Latoya Sellers. So she says, I'm a nurse currently working in substance abuse. We do have clients that suffer from TBI and SA. Are there any resources for them that you know of, or any help tips when caring for them?
That's a great question. We actually have a directory that we have developed for a long list of resources in the community that would be suitable for patients with traumatic brain injury and their family caregivers. And so feel free to reach out to me offline and I'd be happy to share some resources with you.
Thank you so much. And that is all the time that we have for questions, but I will be sending a follow-up email that will also include Dr. Oyesanya's contact information. So you all who are interested in reaching out offline can definitely do that. And so just before we wrap up, I just want to thank you again, Dr. Oyesanya, for your presentation and for joining us today. We were very glad to have you and hear about your interesting work. And our next webinar is going to be on March 10th. It's going to be at the same time. And we are going to have a presentation from Dr. Rebecca Rebe, who's going to be presenting on the impacts of COVID-19 on child maltreatment-related medical encounters and system responses using linked administrative data. And so in the follow-up email that I'm going to send, it will also have the registration link for that webinar. So we hope to see you all as well for our March webinar. And you can also keep up with our schedule on our website. I'm going to drop the link in the chat for you all. And this will have our schedule for all of our upcoming speakers and webinar dates. And these webinars will be going until May of this academic year, so until May 2023. And lastly, in the chat, I'm just going to drop a link to a quick post-evaluation survey. If you all are interested in completing this, this is just going to help us ensure that we're continuing to bring speakers to this webinar series that are of interest, and just making sure that, we can continue to make content that you all are enjoying. And so if you have time, we would appreciate you filling that out. So thank you again, everyone, for your time. And thank you, Dr. Oyesanya. And we are at time, so we will hopefully see you all next month. Bye, everyone.